Hi, everybody. My name is Stuart Schlossman, President and founder of MS Views and News, and I do want to say good morning to all of you all, and I want to say good morning to everybody who's watching online. Thank you very much for being here. And I asked everybody in the audience a few minutes ago if they wanted their picture taken. I want to get everybody's picture online, too. Can I do that? No, I can't really do that. But, you know, I got to have a way to joke around with you anyway. All right. Today's program is a Competence to MS Care program. We do these in rural America and underserved communities around the United States. We do this because we're providing resources during our program that you might not be able to get locally on your local level. And for those that are watching live, then we're hoping that you can use, the information that's provided as well. Today, we have a lot of sponsors. They are exhibit sponsors. And today's exhibit sponsors, we have Alexion, Sanofi Genzyme, EMD Serono, Bristol Myers Squibb, Janssen, Novartis, and Genentech. And we do want to thank them all for supporting what we are doing for this community. All right, next. I'm not going to be talking all day because everybody knows me already, all right? And if you don't, you come see me after the program, and you guys can text me, all right? So for those that are online and those that are in-house, our special guest for today is Dr. Mary Hughes. And Dr. Mary Hughes has spoken for us many times in the past, whether we were here in Greenville or we were in other locations. And she even spoke for us virtually many times in the last 2.5 years since COVID began online. And she'll be speaking with us many more times in the future, as long as she always likes to speak for MS Views and News. Dr. Hughes is an MS neurologist specializing at Premier Neurology here in Greer, South Carolina, and she'll tell you more about herself.
All right. Well, thank you. It is good to be here. He's muted. Okay, now I'm unmuted. All right. So it's so exciting to be live. Bill and I were talking about our presentation, and we got all confused. And I said, well, he's like, I'm here. And I'm like, well, I'm here. I was still in the bed, to be honest. And then it was like, he was like, are you coming to the hotel? I'm like, yeah, where are you? I'm so used to things being remote, the whole language for it. It's so good to see so many friends. And it just is, it's the last 2.5 years, we've had to learn, and we've had to thrive, and we've had to learn how to get our care in other ways. Bree, it's so nice to meet you in person. Many of you know I broke my foot in October, and I'm like so happy that I'm making it to the cane. And that's why all these contraptions. I told Stuart, I have not stood for an hour. I don't think that that's going to be that feasible. But landmarks, and you guys will understand this, my ramp on the front of my house came down yesterday, which is code word for my husband and son, knocked it down. And so, of course, the moment your ramp comes down, that means you can do everything you used to do. No. And so when it got time to get up out of bed this morning, everything hurt from head to toe. But I was frantic, right? I got to get there. Bill can't open my presentation. This is a crisis. And then Bree will love this, because all that good advice I give y'all, I'm having to pay attention to it, because when I tried to get out of the bed, I didn't do my stretching, right? And I almost fell over, and my husband's kind of in that, she's crazy, she knows what to do, I'm just going to watch her. And so I had to get back in the bed and do my stretches. It turns out life is better when you've stretched, much better. And I wasn't in a particularly good mood. I will tell you, I was not. And so part of the joy of doing a presentation is you have to do your homework, right, Bree? You have to go back and look at things. And so Stuart, I love when he gives me what you should talk about. Are you telling me to turn it up? No, you got, okay. Stuart went like this, and I'm like, what does that mean? The part of it is you have to do your homework. You have to look at the literature. You don't want to be quoting yourself from 10 years ago. And so I was we're going to talk about some of the well-being and mental wellness in the pandemic, post-pandemic, endemic, and part of it is what makes you happy. And daggone it, my sequin pants make me happy, and I have been nowhere in the last how many months, so I pulled those sequin pants out and I said, daggone it, I'm loving seeing y'all, but don't miss the sequin pants, because I bought them at a rather low moment, like I guess I'll get to go someplace and see somebody one day, and today was the day. So it's so good to see you, and look at these sequin pants, because I'll be going straight home after this, and my wardrobe is 99% sweatpants, which I suspect most of us. I just kept pretending in the office, like, no, they're really sophisticated work pants. They've been sweatpants. So I thought this... Stuart's asked me to cover, like, you still can't hear me?
I can hear you perfectly.
Well, why are you shaking your head at me?
Not you.
Oh. Well, don't be confusing me. It's nothing like being presenting, and he's like, no, and I'm like, it's the only yes I got, Stuart. I'm holding it together the best I can. But he gives you like 5 topics, and sometimes it's a little hard to figure it out, how they all connect. And so I know many of you are very well educated, and you keep me on my toes, not naming anybody in person, but I'm looking at you folks, and I can't ever say, never heard of that. I guess I'll go have to read a book. So we wanted to start with just some basic MS 101, because before you can talk about living well, caring for your MS, you got to know the basics. And so we'll do that kind of briefly, and I'm kind of setting you up for, I'm excited about the presentation. I learned a lot about the wellness and made me think about it. I'm really excited about some of the advances in MS treatments, and that's one of the things Stuart wanted me to talk about. My practice is literally less than a mile from here. And I was given the Janssen folks. Is the Janssen folks in here? Yeah, there you are, over there. Well, I'm just going to tell, I've given y'all grief because over the last couple years, I did a lot of research a few years ago. I'm going to stop counting. And then the field of MS kind of got quiet. And then we had a burst of new treatments. But the horizon is just as bright, and so I'm going to give away the end of the talk and say, let's get to that. So if I start running over, I know Stuart will tell me, but the horizon of what's coming. So we need to understand a little bit of the basics before we go there. So MS 101, that was his title, not mine. And we're going to go over the who, what, where, why, and hows. Can you tell that I've been watching a lot of Netflix, right? And so I'm totally into, anybody else watch Blacklist? No? Yeah? Oh, it's like binge-worthy. And so you're always kind of, when the mysteries, apparently on a bad day, I like a little shooting. Not much blood, though. I still don't want you to mess up my meal while I'm eating. But a little violence thrown in on TV, resolved in an hour, works for me when I'm in a really bad mood. So what? I've been saying, what is MS for 25 plus years? And the right answer is, we don't know. You already knew the answer to that, right? But the definition is evolving, and I'm going to give you the textbook definition, and then I'm going to argue with it as I talk. So autoimmune. An autoimmune disease means that for whatever reason, your body has recognized a part of itself as being abnormal and is attacking it, all right? Demyelinating. The conductive coating around the nerves being stripped off. We've talked about demyelinating disease, but wait a minute. The wire, the axon, is also a big part of this disease. So is this a demyelinating? Is this a neurodegenerative disease? Is it both? And perhaps one of the reasons we have not been as effective in treating MS, although, gosh, are we so much more effective than we were 25 years ago, right? Is that we're not capturing all of the challenges, all the parts of the MS we really need to be talking about. And so that's part of the research, that's part of talking about, maybe we are getting better and better. Central nervous system, well, that's easy. That's the brain, the spinal cord, and any of its connections. And neurologic events over time and space. I still, every time I put this slide up, I feel like I've just talked big words, and what I really said is I don't know, okay? MS, if I were to poll everybody in there, I'm so scared I'm going to knock this mic over. That's just what we need, right? But I'm a hand talker, so it works. MS, if I asked your experience with MS, we'd hear different stories. We'd hear different ages of onset. We'd hear different response to treatment. We'd hear different times between relapses. We'd hear different recovery phases. And so I just told you we have an animal. But I really don't know if we have a cat or a zebra, because it's all slightly different. But one of the things that's exciting about it is that we're moving from describing. So relapsing MS. Relapsing meant you had an event and you had some recovery. We used to say relapsing remitting. We're trying to get rid of the remitting, because if you're in remission from cancer, do you have cancer? No. If you're in remission from MS, do you still have MS? Yes. All right. So that's a misnomer. Secondary progressive. Over time, people lose that acute phase. They can't say, on October 29th, I fell and broke. No, that's my story. I lost strength in my left side, and then it got better. What they say is, if I compare how I'm doing last year to how I'm doing this year, I'm just not walking as fast. My hand dexterity may not be as good. Now when we get to the mall, I just tell everybody to go on ahead, which is very humbling, because I tell you, I'm slow as molasses. And all those times I said to you, and I'm very apologetic today, oh no, I want you at the mall. I want you to have that enjoyment. Don't worry about people saying, man, you slow as molasses. It's a challenge, isn't it? I'm very humbled by that. Okay, but still go to the mall. And why does Macy have double doors? And you can't find the button to get through? You get halfway, then you get stuck, and then somebody's got to come over. Did I tell you about my husband not letting me go to the mall with lime green rollers in my head? I don't know if I want this on camera. But I've been really having to go back and practice what I preach, right? And so for months, it was Amazon, because I really couldn't get anywhere. And then I needed a coat. It turned 22 degrees in Greenville. Yes, that does happen here in Greenville. And my coat broke. It might have been those extra weight I gained sitting, not doing anything with Oreo's bedside. But somehow the zipper malfunctioned. I don't know what happened. So I had to go to the mall. And I'm good for going left. And why does this have to do anything? Because it's, I'm so glad to see you. So anyway, first of all, my son, I'm with my walker at this point, not that long ago. And my son, when he drives me there, just kind of looks at me. I'm like, would you like to get out the car, get the walker, hand it to me, open the door? And so, gets out and does that, and then he just looks at me. Now he just stops in the middle of the lane. He doesn't care how many cars are behind him. He just stopped. He didn't pull over. So now I got to try to get fast with my walker, get up on the curb, right? You know where this is going. And then I get to the door, and I was really amazed. I mean, there's no handicap button on the side of Macy's. I've already filed a complaint. And so I'm trying to get the door, get the walker, and then all of a sudden people start becoming very helpful, and they were like, how are you doing today? And I'm like, you ain't seen a walker in a boot before? I mean, I had a little bit of attitude. And then I said, where are the coats? And they're like, they're way on the other, by the mall entrance, which is the other side of the store. And so I'm trucking it. And I'm like, okay, Mary, you're glad to be here. You need a coat. You're out in this wonderful. You're going to have to sit and take a break for a minute. That's okay. You're not in any hurry. You're going to get a nice coat. And you sit, and people are just like, I had lime green rollers at the time. I was trying to style my hair. I was trying to pull it together. And I called my husband and son. I was so mad. I was like, do you all even look at me anymore? I thought they were giving me all this grief about the walker and the boot and the moving slow. And those double takes apparently were those lime green rollers in the top of my head. So nothing to do with the diagnosis of MS, but I thought that would wake you up just in case. So MS. So B, because I don't know my right and my left. B is the classic picture of demyelination, all right? Where you see the arrowheads, that is where the told you it was going to be a challenge, conductive coating around the nerves has been stripped off. All right, that's what we've talked about, demyelinating disease. On my left, your right maybe, I don't know, A, what we see is the green is the wires are the axons. Those blobs at the end, those ovoid bulbs, are where those wires have been transected, where they're broken. And so demyelination is part of the story, and we've definitely focused on it. But we got to deal with the fact that these axons also aren't healthy. This is a slide from 1998. This is not new news. And what's even more humbling, if you go back in the history of MS, back in the good old days when people looked in a microscope and drew what they saw, in the 1400s they were talking about MS is a demyelinating disease and there's something wrong with the wires. And so as we start to go back and look at the parts that we couldn't address in the past, had the honor of being on who knows what the name of the committee is. That gabapentin will get to you, won't it? But I was on some committee, and it was talking about how could we advance the research in progressive forms of MS. And it was with those scientific folks that say those big words that I just pretended like I knew what they were talking about. But the reality was the science wasn't there. That was what they were saying. You can give us all the money you want, and please do, but if the science is not there to make that next step, right? We've got to figure out how do we measure this. We got to figure out why is it happening in the first point. We got to figure out, and that's where we are moving in such a rapid place. And so this is really exciting. Bruce Trapp, you know, I'm like a neurology nerd. Could you take a picture with me? I do have a picture with him. But that really was like changing the whole concept, reminding us of the pathology of MS and saying, if you keep approaching MS the same way, was it Einstein that said if you keep doing the same thing over and over and over again, you can't really expect different results? All right. Who? Well, earlier in my career, we spent a lot of time describing the demographics of MS. It was a Caucasian disease. Well, when my sister got diagnosed, that really upset me because I was pretty sure she wasn't Caucasian, okay? I can remember back in the days when beta-serin was the only drug on the market, my sister had been diagnosed not that many years ago, later, and I asked, she's a physician, and she was like, well, you know, when we treat high blood pressure, we look at the ethnicity, because African Americans respond better to water pills, hydrochlorothiazide. You may not need to worry. Okay, something's going to have to happen with this because might need to tie it to me. Let me know if you can still hear me, but it's a little too close to me. But so you looked at the ethnicity of the patient and you chose the treatment so you could optimize it. This is unheard of in MS at the time. And so I asked my beta-serin rep, how many people in the beta-serin trials were African American? Now, you know you've asked a dangerous question when people in suits start showing up in your office. And the answer was, I think, less than 10. So it was the first FDA-approved medicine. We were so happy to have it, but we really didn't know because we weren't in the trials. Oh, where am I going there? If you have an opportunity to participate in a trial and you're appropriate for a trial, then you should consider being in a trial, all right? Because when we ask those questions, how many people over the age of 50, which is a very young age, by the way, very, very young, it's getting younger and younger, how many people over 50 were in the trial? And you go, well, you know, the average age is 40. Well, how do I know it's going to work for a 55-year-old? Right? And so the demographics, we did a lot of describing. We said it's Caucasian disease. Then there's literature coming out of California saying, wait a minute, African American women are being diagnosed at 3 to 4 times the rate. And this is from Kaiser studies where everybody has the same insurance. So there's a changing face of MS. I used to say, good news is kids aren't affected by MS. Now we know 10 and perhaps potentially rising % of new diagnosed with MS are in children. So there's something about MS that's changing, and we're not going to necessarily figure that out all by who has MS. Early 2000s, the genetics of MS. If we could find that gene that predicted who was going to get MS, and then we found out, I think it was 70s, it just kept growing, that there are a number of genes that are involved in who gets MS and who doesn't. It was a little bit of a heartbreak at the time because I was like, well, there's another gene. That ain't going to help me. But genes do things. Genes repair. Genes produce certain proteins. So perhaps from that information, we could start to say, people have different repair mechanisms, and maybe that's another road for research. The central nervous system. So the brain and your spinal cord, and the optic nerve. The optic nerve, 80% of people at one time or the other in the untreated state, all right, and I love saying in the untreated state, will have at least one episode of optic neuritis, all right? Hopefully everybody in the room is in a treated state, all right? But it's interesting, that's really going back to how we were developed. The optic nerve, we call it a nerve, but it's actually just a part of the brain that developed in a different direction, which is probably why optic nerve is so commonly infected. Why? Why do people get MS? Well, that's a sophisticated chart. I don't even know what I'm saying. Chart. Genetics. Women more than men, but men do get it. Genetics, different ethnicities. If you have an identical twin, you have a 50% chance of getting MS. Some people will say as high as 70%, but it's not 100%. So genetics is part of it, but that's not the whole story. Environmental triggers. I love how that's just one small circle. Is it a certain exposure? The theory of, is Epstein-Barr virus one of the things that triggers MS? Well, I'm setting you up for the research. Just pay attention to that. Because there's a lot of interest you'll see if you go to your websites, if you're the National MS Society, MS for Views and News. Isn't Views and News or News and Views? Stuart, I butcher that every time. It's news, Views and News. I can't see it. It's wrapped around. Don't make me fall off the stool, Stuart. But it is behind me, so y'all should know who it is. But you've seen over the last few months a lot of excitement about, is Epstein-Barr virus the mounting thing? So what I would have told you 5 years ago is that people who have been exposed to mono, who had severe cases of mono, were more likely to develop MS. 90% of us at some time or other have been exposed, right, by our adulthood. There's never been an identified active infection in the brain. All right? And your risks for developing MS happens probably established before the age of 15 to 16. Now, if 10% of MS cases are at pediatrics, less than 13, you start to see how all these descriptions start to, don't necessarily make sense. Vitamin D. People with MS are more likely to have a vitamin D deficiency. May have a difference in how they metabolize vitamin D, right? So it's not like, we usually say you need 15 minutes of sun, and in South Carolina, we normally see 15 minutes of sun on a pretty regular basis, except for the days we're buying coats because it's 22. I think it was shiny in sunny in 22. So why would we see so many vitamin D deficiencies and really remarkable vitamin D deficiencies? 10s, 11s, 25. So we've been advising that people supplement their vitamin D based on their labs. The goal for normal, according to a lab result, is probably between 30 and 100, depending on your lab. We recommend people with MS try to get a little higher level, over 50. Some people will say over 65. So that's an environmental figure, but we can't really figure that one out. It's not sun exposure, all right? But whatever it is, a cascade gets started. And then, and I love the way you just said, and then something starts. And we start going and seeing the evidence of demyelination. Here's one of the challenges. Now that we can look at the axons, we're doing very sophisticated imaging. Not a lot of people donating their brains to say, count my axons, right? We want you to keep it until you absolutely don't need it anymore. I started to make a man joke, but I'm going to leave it alone. I've just been so far off the Stuart wasn't paying attention, so we'll leave it alone. But the women in the room just nodded, so we got where you're going. And so where is this cascade going? And then the loss of myelin, and for many years that nerve fiber would not have been on there, all right? So we're changing how we're discussing MS, changing how we look at our treatments, changing in how we look at our targets. Most frequent symptoms, If you poll people with MS, 90% of people will say, I have some type of pain. And we spend our time figuring out, is that nerve pain? Is that stretching pain? Is that spasticity? Turns out I have a lot of spasticity, Bree, so I'm about to become a patient. I'm like PT twice a week, stretch zone twice a week, a massage when my husband is still talking to me. No, I have to go pay to get a massage, not at the house. And so what are all those things that we can do to kind of address pain? Two most common causes for leaving the workforce: fatigue and cognitive. People with MS don't get demented or any faster than anybody else. But they have problems with attention, concentration, easy distractibility. I never understood fatigue until I broke this daggone foot, all right? I look across the room and I said, you know, I really, really need to go to the bathroom. Do you know how much energy it's going to take for me to get from here to there? And then I got to come back. So, and you got to plan it. But these are, I'm preaching to the choir, so the slide is for those who are new to MS. But y'all already know, all right? Anything that the brain or spinal cord is in control of can be a symptom of MS. And we spend the vast majority of our time caring for people addressing the symptoms of MS. And we can make enormous improvements in quality of life. I am still mad at my surgeon, and I will tell you right now, I broke my foot. You know, some people break one bone, some people break two. I went for the Holy Trinity. I went for three. He forgot to tell me that right under them bones was a I'm a neurologist, I don't even know what you call it, ganglion something, right? And if he tells me one more time, those x-rays look great, but the fact that every time I step down on that foot, I want to scream. So, you know, how do you, and I will tell you, the surgeon did nothing. He was like, you just keep doing. I had to kick in and go, like, there's some medicines that people use for that. And can I confess, I got 2 patches on my back right now that got menthol, so don't get too close to me. If you feel like you smell an old lady, you are. But it helped my back, I'm up. And so all of these things that we can treat, that's what we spend 90% of our time caring for when we're caring for people with MS. Sometimes people ask, do you need to see an MS specialist? First of all, I'm not 100% sure what that means. It usually just means you're getting older. But the other side of that is we know that if we're going to improve quality of life, we've got to focus more on, have you had a relapse lately? All right. How's your MRI look? All right. And this presentation doesn't spend a lot of time on symptomatic management, but certainly the MS Views and News or News and Views has some really great videos on talking about, and I encourage that. I can't cover everything in this presentation. Stuart wanted me to talk about access to care. The last 2.5 years have been really interesting. All right. Notice the in-person visit. It's on, you know what it looks like. I can't tell right from left. You know, the one with a doctor sitting in a chair. It's been updated because they're both wearing masks. And you're in person versus telehealth. In 1999, I was in Augusta, Georgia, and they had a telehealth clinic for some of the outlying centers. Now, it was massive. It looked like we're down to 2 cameras now, but there was big screens, and I was talking to places out in South Carolina, Georgia, and there'd be a doctor. It was really a humongous undertaking. But we were doing it because we knew it was effective, that we could reach people that we couldn't reach in the office. Stroke care has been revolutionized by telehealth. All right. I had the pleasure of helping develop the stroke network here in South Carolina when I was at GHS, now Prisma. And if you were having a stroke in Timbuktu, South Carolina, you know there's lots of those, right? The advice is to go to the nearest emergency room, but I'm gonna tell you, there ain't no neurologist there, all right? I could reach you from I tried to get out of bed, all right? From my computer, do a standardized assessment, and give recommendations that would change your outcome. It's been verified, validated for years. It is standard of care. When the pandemic came, all of a sudden we had to look at how we develop care, right? Why hadn't we been doing it? When I first started my private practice, that was a big part of what I was going to do. There was one small challenge. Insurance companies didn't want to pay for it. And I will tell you, through this is peeves with the insurance company, Blue Cross Blue Shield, every 3 months would say, we are no longer going to pay for telehealth in the middle of the pandemic. Every 3 months, they just threatened it. Not going to pay for it. Not going to pay for it. They'd wait till like the day before and they go, okay. And what really irritates me is, has anybody heard about Blue Cross Blue Shield telehealth resources that they are now providing to the community? Do you know why? Because it is effective. It reaches you where you are. I did a lot of telehealth when I broke my foot because I was like, oh, I ain't coming to your office. I can tell you what my blood pressure is from the house, and we can talk about what we need. Sometimes you got to lay hands on me, all right? But you don't need to do that once a month. In the world of MS, when we transition to that, there have been a lot of people who've looked at, have we been as effective? Could we reach more people? Could we still manage your care? And the literature says, yes, we did well. Was it awkward? Yes. I am not, can you tell I'm not the most tele-equipment kind of person? And I'd so much rather be in a room with you, as long as you're wearing your mask and you're vaccinated and I'm vaccinated, all right? You know what's funny? Is people would keep canceling their telehealth visit. I'm gonna wait till you can see me in person. I'm like, well, I can't wait. We kept waiting and waiting, and then people were like, listen, I think this might be going on more than 6 months. Maybe I need to go ahead and do the televisit. Now, people call in and say, listen, could we just do my next visit by televisit? Right? I haven't had an MRI. I'm doing good. We just need to talk about my labs. We could do that over telehealth. So we've seen this whole transition in healthcare, but it wasn't new. All right? What was new is that it was available. The Army, the VA has been caring for soldiers across the seas with specialists. How many dermatologists do you think there are in Iraq? You think they need dermatologists in Iraq? Yes, they do. All right? They've been doing it by telemedicine. And so what's new to us is just now that it's coming into our mainstream. All right? And thank goodness the technology didn't look like it did in 1999. All right? To say we could roll right into it. And I don't think it's going away, right? I don't think it's going away because the convenience of it, and because we have actively looked at the efficacy of it. Does it work? Are you doing well, right? If you needed to, we brought you in. Nicole would spray that office down so your eyes was watering, but we brought you in, right? And I think that changing how we care for folks. So I think that's what Stuart wanted me to cover on access to care. It's not going anywhere. Okay, let's get to the good stuff. MS treatments in development. There are over 2,000 MS trials registered as of December 2019, and it has not gone down, okay? I just couldn't find a slide. I wasn't in the creating slide. I didn't create any of these slides. All these slides are, thank you, Dr. Balshifa, for doing such a great job putting that in one slide, all right? Over 2,000. Now, a lot of those are animal studies. A lot of those are test tube studies, right? So then you kind of go, well, what's pertinent to me? There are 147 phase 2, phase 3 trials that were currently active or completed within the last 3 months. So you have your animal studies. Then you have your phase 1 studies. A phase 1 study says, is it going to kill you? It says, is it safe? Right? That's where you hear about college students getting paid to come in and take the study drug, and their labs are checked every 30. We're just looking for safety. All right? We're not even asking, does it work in a phase 1? We're just like, is it safe as far as we can tell so we can move forward? A phase 2 trial says, all right, it looks like it's safe. It's safe enough to continue. We're still very interested in the safety, but now we're starting to look at, can we see that it works? Is there a signal that we can say this works? Generally speaking, what we're talking about is MRIs. For every one time a patient knows that there has been a neurologic event in the untreated state, the MRI can show up to 5 to 10 new lesions. That's very humbling, right? That's why we have to do MRIs. We had to juggle that in the pandemic. Do you know it takes 4 hours to turn over an MRI at the beginning of the pandemic, just from one patient to the other to make sure it's cleansed? That's pretty amazing, right? So we had to make decisions. So if you hadn't had your MRI, I think this year is going to be the year. Hurry up, okay? Hurry up for the next. Hopefully there's no more phases, but hurry up. So phase 2 is looking at, does your MRI improve? Or is there less lesions, right? We're starting to hint at that. What I'm really excited about is we're also starting to ask patients, how do you feel? Phase 2 trials, are you getting sick? Do your labs look okay? And how's your MRI doing? Patient-reported outcomes. Can you tell a difference in how you feel? Y'all are like, why weren't you asking those questions? I'm like, I didn't design it, I just lived it. Phase 3 trials are the big trials, all right? We said it's safe. We have a signal that there is supporting evidence that this may change the disease course, whatever the outcomes we're looking at, whether it's relapses, whether that's progression of disability, whether that's whatever you're talking about, all right? And you enroll 1,000 people. Some people are on the real drug. Some people are on a usually active comparative now. We have so many treatments for MS. It's not, only in very unique circumstances, it's considered ethical to have a placebo, okay? Or a sugar pill. Usually not given by a pill, but you know what I mean, all right? And there we're looking for clinical outcomes, meaningful outcomes that talk about the disease process. Now, those are phase 3. And to come like, how close are we? 34 trials testing innovative MS drugs, not necessarily looking at the same thing. I'm sorry, there's some people in here from various drugs that what we did was we took this drug and we made it better, all right? And then we changed this receptor because the reps are in the back of the room, all right? And so I got to talk nice. Thank you for sponsoring the program. You're not paying me, but thank you for sponsoring the program. But it was kind of like, can we take a good drug and make it better? That is important. But we also need to ask, is there something we can be doing different? All right? And so the phase 3 trials. I'm only going to talk about 2 treatment approaches, the BTKI inhibitors and the EBV, Epstein-Barr Virus targeted therapies, because I have no idea what time it is, and y'all know you like to ask questions. So then we'll turn it over and we'll let it become your presentation. The BTK, before we start getting into that, we have to talk about how we're approaching the targets in MS. What I really love about this slide, this image, is you see where it was published? Not in the Journal of MS, but in the Journal of Internal Medicine. What does that mean to us? It means that MS is not this disease that people back away from and nobody knows anything about it, which it still is to a certain extent. But that we're educating our primary care physicians, that we're talking about what are the advances, what are the new approaches, right? And we need that, because I ain't a real doc. Y'all heard me say that 100 times. I'm not a real doctor. You call me and ask me about your toe fungus, I'm going, what'd your doctor say? Which blood pressure medicine? I don't know. I really can't keep up with all the antibiotics. I got a bladder infection. I need to know because, yes, bladders are affected by MS. But I also want you to get the most current recommendation for antibiotics for that particular, and they change. Turns out other fields are showing or having new innovations and growths and new drugs. I watch TV just like you do. I just be writing the names down. What's that? That's used for what? So it's really embarrassing when a patient comes in. I say, can you spell me that for me? And then what's that used for? But I'm not embarrassed anymore because there's so many drugs, right? We need to know what they are because we don't want you, for example, on 2 drugs that affect your immune system, right? And there's so many drugs that are being used in dermatology and GI and rheumatology. I may not recognize the name. And guess what? Your rheumatologist may not recognize the name of your MS drug. And we've run into that, right? And be like, whoa, you can't take those 2 together. They're like, I told them I was on X, not gonna say a drug, see? All the pharmaceutical reps went, I'm like, no, not gonna say a drug. But you can't take X and one of those drugs you see on TV. We shouldn't take them together. We don't want to be a impacting your immune system from too many different directions, all right? So I love it's in the Journal of Internal Medicine. I love that. When we first talked about early generation drugs, we really were talking about affecting the immune system in the blood system, in the peripheral vasculature. Could we go after the immune systems that were in your bloodstream? Could we keep the immune cells that were hyperactive, reacting to something abnormally, from crossing from the blood vessels into the brain? Could we decrease how many immune cells that were misbehaving? All right? We talked about the blood a lot. We still talk about how do we affect the blood. Then we started thinking about, well, you know, those immune cells, you know where they're stored? Or in your lymph nodes, right? In your spleen, in your bone marrow. Is that another target for impacting the immune system? And it turns out it was. And it's a very effective one. All right. What we haven't had is a drug that actually penetrates and goes into the brain itself, crosses the blood-brain barrier. I guess I shouldn't say that. Newer generation drugs have been developed so they're more fat soluble. I don't know if that's the medical term, but you know what I mean. Fat soluble, so they could cross the blood-brain barrier and have an effect there, right? Because that's where that's the end-stage damage. The damage from your MS is not in your lymph nodes, all right? That's just where those immune cells are sitting. All right, and we'll talk about if we can affect what's happening in the brain at the brain level, can we be even more effective? Can we remyelinate? Can we increase the health of the axons? We really know that there's something called B-cell nests. Has anybody heard of a B-cell nest? No, me either, to about maybe 7 years ago. B-cell nests, we didn't know that there were accumulations of immune cells along the surface of the brain. The longer you have MS, the more B-cell nests you have. Well, I guess they're probably doing something, right? Somebody said, maybe they're doing something. Maybe we should go after that. Maybe we should try to understand that better. All right? So that's the third target that we're going to talk about, is the saying we're actually looking within the brain and saying, can we make changes there? All right, I started saying BTKI, and I always wondered where people just kind of get this started. For those of you who are really into serial killers, apparently there is a serial killer called bind, torture, kill. That was his phrase. But then I'd say, like, listen, we're talking about MS. Do we really care if we bind, torture, and kill? But I'm not trying to, when you're offering a treatment, you're not trying to bind, torture, kill. All right? So we're not talking about the serial killer. But we are talking, and I'm going to say it once, and then y'all can read it. The Bruton tyrosine kinase inhibitors, also known as the BTKIs. It takes all day to say that. All right? And this is an interesting approach. First of all, we had to figure out that there was a receptor. And then we had to figure out, what does that receptor do? And what that receptor do is modulate. And it turns out we can impact that receptor. And every time I say, this is what this drug does, this is what this approach does, if you go in the fine print, what does it always say? We have no idea how this drug works, right? Because we may not even known about this pathway over here. And until we discover that pathway, we don't know whether it's being impacted. So maybe I'm looking over here and saying, look, your white cells in your lymphocytes in your bloodstream are down. That's how it's working. And maybe that has nothing to do with that. That's just a side part. But the real activity is being done over here. All right? So disclaimer, this is what we think it does. So the BTK inhibitors, for the last 2 years, the nice thing about being virtual is you can be virtual in Australia. You could be virtual in Spain. You can be virtual in Italy. You can be virtual all over the place. And what that meant is like, I'm not going to be going to Australia anytime soon. But we could talk to each other, people who are interested in MS, through opportunities that pharmaceutical companies were very happy to offer us, and other sources. They're like, we don't have to pay for your dinner, but would you mind talking for an hour to a researcher in Australia? And you know, it's kind of boring for the last 2.5 years. I'm like, yes, maybe I need to get out more. Okay, maybe y'all would have found something else to do. And like, yes, let's discuss MS, 7 o'clock on a Tuesday night. But we learned a lot. And one of the things you kept hearing is when people they like to ask, what do you think is the most exciting advance? And you kept hearing the BTKI inhibitors, all right? What's different with the BTKI inhibitors? I don't even know what the next slide says. You know, I hate slides. I like to talk on a slide, but not the 50-minute slides. If we're modulating the response, so we said, for whatever reason, the body made a mistake. It starts to recognize a part of itself as being abnormal. And your B cells are the ones that says, here it is, whatever it is. It says to the T cells, come get it. But if you can modulate that response, if you can do that without killing cells off, right? Because that's sometimes what we do when immune suppressant drugs is we decrease the number of cells you had. We learned a lot in the pandemic. Turns out we do like your immune cells. All right, and that we had to learn about, is there anything we need to do for people living with MS? Should they get vaccinated? Are they safe getting vaccinated? All right, of course we'll cover that in a minute. All right, and so looking at this approach, and what's interesting is this mechanism is present in people relapsing remitting MS, secondary progressive MS. So where are we 15, 20 years ago? Predominantly described MS by how many events and what your clinical course was. That didn't necessarily mean that there wasn't a commonality in the target, right? And that's what we're finding is where is that commonality? Where should we be going after to hopefully change the course? Over the last 2 years, we are now doing 4 different BTKI inhibitor trials. Why? Well, because it's a hot new thing. And it's great to have the opportunity to be able to participate and give people the opportunity. But even while the trials are being done, they're trying to make improvements to the drug. Everybody has a little different, right? And what's interesting is we didn't study the same drug in relapsing remitting and secondary progressive, because we presumed that this would only work for relapsing folks, right? We rarely had this worked for relapses, but maybe didn't have as much effect on progressing. Or, well, it had a pretty good effect on progression, but look what it did for relapses, right? So we were always kind of weighing that. We still are to a certain extent, okay? But it's broadening our treatment options and looking at different approaches with looking at a common pathway that is abnormal in people with MS, not necessarily relapsing versus secondary progressive. We're getting away from description and getting down into what's common between the two. What's ironic is, did anybody, I'm looking at all the pharmaceutical reps, and where's Stuart? Was anybody at the ACTRIMS meeting? Okay, so I wish this presentation was next weekend. So the American Committee on Treatment and Research in MS, which is a fascinating meeting, you should all go, happened just this last week. And I wasn't ready to travel to go. And I can't wait till everybody gets back and tells me what happened, all right? And so looking at what's the most, nobody's nodding their head. I mean, travel budgets has been slashed. It was in Palm Beach, so I was thinking, Stuart, he just left me by myself. What if I got lost? So maybe we'll have even more, but I can tell you, when I'm looking at the trials and quoting them, we're talking about July 2021. We're talking about October 2021. We're talking about recent data coming, all right? And so the newest updates, so you'll have to have me back again next month so we can do it again. The Academy of Neurology meeting is beginning of April, and daggone it, if you have to roll me in, I'm going to be there. Not for MS so much, but for all the other diseases that have seen improvement. But this is, you got to stay right on it, right? You got to stay right on it. Because as these meetings are coming, this is where they hold the information so that they can, they give teasers like we're going to be talking about. And they want to be able to present it when there's a large gathering of people who are specifically interested in MS. So how can you find this information? I bet you MS Views, daggone it, MS Views and News, I've done this for years, I can't keep it straight. MS Views and News probably is going to have an update. The National MS Society's website is probably going to have an update. It's worth going and looking because this is a very dynamic time in research in MS. The Epstein-Barr virus has been blamed for everything, all right? And it is guilty for a lot of things. We know that Epstein-Barr virus is maybe a trigger for lymphomas. It is probably a trigger for autoimmune diseases, not all of them, and not for everybody. Although, with the newer testing, 90% plus of people with MS test positive for Epstein-Barr virus, all right? So if it's so common, Stuart, I was just talking about, did you go to Actrams?
No.
It's in Palm Beach, wasn't it in Palm Beach?
It's there now.
Oh, it's still going on.
It's going on now.
Okay, well, I knew everybody was flying out
So we couldn't be there.
Yeah. Okay, I'm here, so I couldn't be there. Something like that. So I was saying, I hadn't gotten any updates yet. Okay, I'm a little too eager. I told you I couldn't wait till Monday. Epstein-Barr virus. So this is from the CDC, and this is photos of cells that are infected with Epstein-Barr virus. The key is latent infection, all right, not active infection. And I say that because I get concerned when people hear Epstein-Barr virus, and people will say, well, I'm going to go on therapy to get rid of my Epstein-Barr virus. Scientifically, it is, a lot of the approaches are not very scientifically sound, and they're very expensive. And so although I'm going to talk about the excitement of Epstein-Barr virus, what I don't want you to do, or to gauge very carefully, is whether or not you should be treated for Epstein-Barr virus. All right, interestingly enough, this corner of South Carolina going into the Asheville area is a big area for complementary medicine. All right, some of it's good. I'm doing some of my own complementary medicine. My acupuncture appointments are twice a week. I think that is fabulous. Who has not been for acupuncture? It's for pain, right? Or used for other things. So I'm embracing complementary medicine, but also trying to embrace what has good science behind it, all right? So don't go out and pay $1 million to have your Epstein-Barr virus eradicated from your body, all right? That's what I'm trying to protect you from. I don't think there's ever been an MS presentation in the last 15 years that somebody didn't say, what about bone marrow transplants, stem cell transplants, all right? Because it's usually you, right? Autologous, I'm just going to talk about the terms. Autologous is when you take your own cells and then they wash them, clean them, grow them so you have more of the healthy cells and give them back to you. They're your cells. There's a bit of a problem with your cells, right? Because you wouldn't need an autologous unless there was something wrong with your cells in the first place. So there's always been kind of this question, is that the best source? Allogenic is someone who donates their cells and they are grown, and then it's like having a blood transfusion. You have to match that donor's immune system. So allogenic is you're getting it from somebody else who had a healthy immune system, and it's grown, expanded, and then given back to you only after you're very closely matched that. So it's the difference between the traditional bone marrow transplants. If you've ever known somebody who had a bone marrow transplant, if you've ever been involved in the care of people with bone marrow transplant, it is not a small procedure, not without a lot of risk. We take your immune system, we knock it out, then we try to get you a new one, and we got to grow it back. And for a while there, you are totally not protected, all right? And the process of knocking out your immune system is not pleasant, all right? If we can give you healthy cells without having to go through all that process, look at how the science has come, right? We take out the risks, we take out the concerns. And if we can give you a healthy immune cell, what can we do with that? So what if I was able to give you a healthy immune system? And I'm broadly using terms, okay? Broadly use. I mean, we could go into a lot of acronyms. Not on gabapentin. No, I'm just kidding. But like, who didn't tell me these drugs make you a little foggy? You know what I noticed was I love to woodwork. Well, you don't know I love to woodwork, but I love to woodwork. And it's better if you're standing. Much better if you're standing, and if you're steady. So I hadn't been able to do that. So I could crochet. I love to crochet, but it does not compare to woodworking. But I couldn't count. I'd be like 10. No, that's not 10. I'd count back over and over. I'm like, what have I done different? And so we have to be aware of that. Okay, side story, just to make sure you're awake. So what if I could give you a healthy immune system that was Epstein-Barr virus negative through a process that was, at this point, giving you an infusion? Is that going to change your outcome? It almost sounds a bit science fiction, except we're doing that. It's a phase 2 trial, and people have to be matched. You have to have a donor match. So your first step, because you can't go any further if you don't have a donor, right, is you come in, you have lab work drawn, we wait very impatiently. Because every day we're like, is there a donor? Is there a donor? If a donor is found, which I think they say 90% of the time, would you believe there are banks now? This company and there are other companies specialize in having these donor cells. Because it's not just MS. It's a lot of other autoimmune diseases that are looking at this approach and being treated. So they specialize in having donors, not 100% match, right? Those of us in the room who are African American, we don't like to donate. We might want to donate because it's hard for us to get a match sometimes. I have somebody who's Puerto Rican right now, and I'm like, I hope you have a match, right? Another plug for when you can, please do, right? For the record, I am a donor. Many years ago when I was young, had energy. No, I'm just kidding. Back in the day, you'd have a hard time asking me today, right? But no, stop encouraging me, because you're just sitting there nodding with me, and then you and I like, oh, okay. All those times I talked to you and supported you and just said you're going to get through it. She's like, it's your turn. All right, so once a match is found, it's given by infusion. It's given by infusion in cycles, so so day 1, day 8, and day 15, you love trials, right? Because it's day 1, day 8, day 15. And it's 2 cycles a year. The initial studies, the very phase 1 studies, where you're just looking to see if it's safe, suggest that it is very well tolerated. Now, we follow drugs for a long time. You've all seen drugs come to the market 10 years later, right? And say, oops. We can think of some things that got pulled because, wait a minute, if you expose it. But right now, it looks like it's safe, it's well tolerated, appears to be well tolerated. And the concept is, if I give you a healthy Epstein-Barr virus negative immune cell, the reality, your immune cells go through cycles, all right? They grow up, they get old, they die. Then the next ones grow up, they get mature, and then they die. What if I give you a new one that grows up and replaces those ones that are dying so that you're getting a new population coming in? Probably very, very, I don't know if that's simplified. I call that Hughes level, all right? That's how I have to understand it, all right? What's the potential benefit of that? We talked about remyelination. Could we do that? Can we keep your axons healthier? We can't fix them once they're broke. Once they're broke, they're broke. All right. We don't have a way to regrow an axon yet. All right. And you need both to be fully functioning. But that's looking at it in a very, very different way from decreasing your immune cells, trapping your immune cells, shifting your immune cells, trying to get immune cells into places we've not got immune cells modulating them in spaces we haven't talked about before. All right. So again, a very fascinating. You can go, Stuart. You got something on the Epstein-Barr virus, the TARA trials on your website?
Yes.
All right. It's It's out there, it's exciting, and it's in progress. It's just from a hope. Where are we going with the treatment of MS? Where are we going? All right. Stuart, how long have I been talking? Too long? Oh, never. Okay. Wellness, this was the one that I knew I needed to talk wellness, and y'all know I can talk some wellness. But I have been humbled. All right? I have been humbled. You know. First thing in a pandemic is, what do we do to keep you safe? And it's fair to have a lot of questions. And if you have a physician who has not discussed with you whether or not you should be vaccinated, you need to fire that back. Because the biggest threat over the last 2 years is whether you're going to live or die. All right? The fact that we're all still standing says congratulations. But there are a lot of us who are not. All right? Over 11 million people have been vaccinated. That's my answer to folks who say, I'm waiting to see if it's safe. I'm like, well, when we vaccinate 11 million people, 8 million children under the age between 5 and 11, I'm going to say there's a pretty good safety signal on that. I'm young and I'm healthy, and I'm going to be able to fight COVID. I've lost some people. And I've lost a lot of people through the office that I know, their family members. We've grieved a lot over the last 2.5 years, all right? If you are not vaccinated, I'm probably not going to convince you today. Yes, the numbers are going down, but it's kind of going to be like the flu. That's what an endemic is. It ain't going nowhere. We had a flare up, but guess what? It's kind of probably going to be like the flu. What's this year's season going to be like? But it's not predictable, right? And so if you're not yet vaccinated, it is not too late. If you're not yet boosted, get your booster. Do what you can. All right? I can't take care of your MS if you ain't alive to be there for it. I was much more soothing in my initial vaccination talks with Stuart, wasn't I? I'm done now. I'm like, you want to live? There's been a lot of studies looking at the safety of MS. That's part of a lot of those conversations that I was having virtually all over the world. The bad news is, I'm sorry for them, but Italy went first, New York went first, Australia went first. We could learn from their experiences. Israel went first. So we could learn from their experience and learn from that and share that information with our patients here in the United States to give them advice, all right? And likely safe is the mRNA, and it's different language, and there are fabulous videos. I couldn't even find my video. Maybe Stuart's taken my video off. But he has so many videos on the vaccines, because that was such a hot topic. It remains a hot topic. I am so excited that the CDC is starting to talk about when can we take our mask off. South Carolina is still at a moderate to high risk. All right, we're not ready yet, and that's why I'm glad you're all wearing masks, which was mandated, but wearing masks. I hadn't taken mine off. All right. You know what a challenge is? Is then we had to start asking, okay, it's safe for people with MS. It's not going to increase your relapse rate. It's not going to change your progression of disability. It's not going to affect your MRIs. But y'all are on these drugs that affect your immune system. And they are powerful. And are you going to get the same safety response based on what drug you're on? We weren't recommending changing your MS drug. Right? You've been doing well. If it ain't broke, don't fix it. But we may need to put a different protection around you. We may need to talk about when you should get your vaccination. We may need to talk about how many boosters you should be getting. All right? It certainly has impacted as we begin people on treatment, right? As we talk about going into the endemic, where we're going to be living with this, to talk about how do we move forward with that. EvoShield. Anybody heard of EvoShield? Good. I hope I'm like looking. Some of y'all should. EvoShield is an emergency use, and the fact that all of us don't know about it just tells you how sometimes the science is ahead of us and we don't know about it. You've heard about people when they got COVID, and if they were bad enough, they were given an antibody infusion to try to decrease the severity of their disease process. EvoShield is one step before that. It's saying somebody's at a high risk for having complications from COVID. Pretty much if you're alive, you're at a high risk in my book, all right? But the risk factors are age, their weight, their comorbid, if you're diabetic, if you're hypertension, if you have an autoimmune disease and you're on a treatment that affects that, all right? And when it's a combination of two antibodies, and it's giving it to you before you get sick, all right? To say, can we give you an extra layer of protection beforehand, all right? At this point, we say it's protective for about 90 days, only because we've got the data for 90 days, all right? Time keeps going. We can't wait a year and say, hey, it kicks off at 6 months. You may need to get another. It's just one injection. It's 2 injections IM. It is something to be aware of. I know it's on the National Mess Society website. I'm sure Stuart has something on it right there. All right. And so it's out there, and that's part of the role of being proactive and caring for yourself and saying, coming in and saying, should I be a candidate? Am I a candidate? Should I be doing this? Just so you know your options. Does not mean don't get vaccinated, just do the Evo Shield. All right? All right. This slide just took me down. Wellness with MS. If I wasn't having a good day this morning, I was having a worse one yesterday. I was just in a mood. It turns out it sucks to hurt. It sucks to be moving slow. It sucks to have to ask people for help. And as happy as I was when that ramp came down, you know what that meant? Now I got to walk down the steps, right? Physical therapy, 8 a.m. in the morning, I am not a pleasant person, all right? I walk in there and go, what new torture do you have for me today? And guess what? They keep finding them, all right? But I'm getting there. I miss my friends, right? I mean, I came in here just like, oh, hello. Stuart's like, Bree, you still talking? I'm like, but I had. All right. Sorry about that, Bree. I just got a little too excited. All right. I wore my sequin pants because I ain't been nowhere. All right. And so our lives have changed. And how do we stay wellness? Despite a COVID pandemic, this is the wellness slide that just said, hey, it's a little harder during a COVID pandemic. All right, let's face it, it's a lot harder during a COVID pandemic. And if you already have challenges, if you already had challenges getting out, the pandemic did not help. All right. If you are at a higher risk we told you don't go out. Wear your mask, wash your hands, stay away from crowds. That meant a whole lot of restaurants came off my list, although I love me some DoorDash, all right? So we had to think about different ways to look at how we could work on our well-being. I spent more time outside. Okay, my husband put me in the truck, then we went for rides, all right? Connecting to nature. I'm not really a nature person. I like looking at it. I don't want to be in it, okay? I gardened. I did a lot of gardening. And wasn't it just nice? You just drive down the street and everybody's yards look so nice as we were home. We had plenty of time to make sure we pulled them weeds this year. I don't know what next year's going to look like. My husband better get to it. But like looking at what are the things that you really enjoy. For a while, I was just miserable. I was like, I can't use my power tools. I can only use my crochet hook, and trust me, that is a big change. Except then I started crocheting Christmas hats, and you know what, the little girls across the street, I have made so many Christmas hats this year. If you need a Christmas hat for next year, I gotta stand by one because I got more than I ever, and people are like, it's 70 degrees outside. We really don't need a crocheted hat. Connecting to people in a different way, all right? Zoom family birthday parties. Seeing people that you wouldn't have seen, right? We found ways to do it. Staying healthy. Well, how many people put on the COVID-15, COVID-19? All right. Then I had a break and a foot on top of that, okay? I had choices. I could have told my husband not to put the Oreos right by my bed. I could have. And I'm sure he'd be like, he'd wake up at 2 o'clock in the morning, I'm chomping on an Oreo. But finding ways to stay healthy. And a lot of us put it on and said, listen, we don't know when this is going to end. We better slow down with this. How can we exercise? Walking. What can we do? Yard work. We had to find new ways. All right. I like this slide. This is interesting. Where do you think I got this slide from? Well, actually, it's this one. This one is from a veterinary school in Ontario. This is what they developed for their students. It doesn't matter who you are. The rules are the same. We had to think different ways. Money was funny. People weren't showing up for their appointments. I understood. Blue Cross Blue Shield said, I ain't paying you to see them by telemedicine. I'm going to pay you a third. Jobs disappeared. Restaurants closed. We had to find new ways to get around that. We couldn't go to church. I do not find sitting in my car in a parking lot listening to church a good experience. I'm sorry. I don't. I had to find a new way, right? Social. I'm a social person. I like seeing people. For about 6 months, I was the only one in the office because somebody had to be there when they dropped off deliveries, and I had never heard of web fax. So I had to sit by the fax machine and then scan it and send it to somebody. Turns out you can just get it by the web. Things you learned during a pandemic. Gyms. Is it safe to go to the gym? Well, it depends on what time you go. And I ain't going to exercise next to somebody who's, all right? That's what I sound like when I'm in the gym when I return. Okay, it's been like 6 years, but I'm going to have to return if I ever want to get back to my baseline, right? So finding safe ways to do this. I hear who had the home gym? The home gym. I took the clothes off my treadmill so my husband could walk. I didn't get on it. But, anyway. So finding new ways to do this. Stuart, if I don't do any other slide, I want to do this one. A big part of wellness during the pandemic, wellness with MS, wellness with a broken foot, wellness with whatever challenge you are facing, is identifying what you cannot control and identifying what you can. And that took me, I walked around. I didn't walk around, okay. I sat in my chair and I leaned back and I have a recliner, leaned it back. And this one hit me. I can control my attitude. I didn't think y'all liked the attitude I had first thing this morning. I can turn off the news, and now we got a pandemic and a war, right? I was sitting in front of the news with my phone checking the numbers for COVID, and it was messing with my mind. It was messing with y'all's minds. Anxiety levels are soaring. That's one of the reasons why we have these mental health talks for everybody. I can control finding fun things to do at the house, even if I can't use a power tool. All right, there are things I enjoy doing. I can't control when the next surge of COVID is going to happen, if it's going to happen. But I can control whether I get a vaccine or not. All right. I can't control that my gym is closed. I do have a membership, Bree. I keep a membership because it looks good. All right. But I can't control who's around me and what they're vaccinated. We live in South Carolina, okay? Do I need to say more? For those of you who are watching us remotely, we live in South Carolina, and we just leave it at that, all right? Big old sign saying, do not enter without a mask. And you people go, stop me if you can, and there's this concealed carry thing. I don't mess with it, all right? I cried over toilet paper. I did. I could not find it. I was on my 4th place, and it was just at the end of my rope. And my husband's like, do they have Bounce? The sheets for the dryer? And I'm literally standing in the middle of Target, probably with other folks, looking at the empty shelves, and I was at the end of it. I was crying. And he said, well, can you get some dryer sheets? And I'm like, I am having a crisis here, and you are asking me about dryer sheets. And I don't think I can tell that joke on. Okay, I'll tell you the rest of the joke later. All right?
I want to hear it.
Because it won't come out wrinkled and it won't stick. And I just did not find that joke funny in the middle of Target. Okay, but somebody said Pam. So it doesn't. So there's just lots of jokes about it. Yes, I've cried over toilet paper. All right, standing right next to tissues, which technically just cuts different. But that went out too. All right. I can control who I phone, who I call, who I reach out to and say, listen, I hadn't talked to you and I need that connection. I've spoke more to my friend who's in Hawaii than I have spoken to her in years because we both home. No. All right. Because I wanted that connection. I needed that connection. All right. To survive that. And so if you've had a hard time, okay, if you say you haven't had a hard time the last 2.5 years, you're lying. All right, that's first of all, we already know that. But I like this mind thought. What can I control? What can't I control? All right? And that's very empowering. When I put on my sequin pants today, I marched in here. Okay, I limped, hobbled, whatever. But you saw me coming, didn't you? I didn't have to say I'm Dr. Hughes. The sequin pants must be Dr. Hughes. No. All right. And so really looking at that, the journey's not over. And I think there are a lot of, you guys are ahead of the crowd. But you probably only had $1. In the last couple of years, I've asked you to spend $1.50. $1 for how much resilience do you have for using your walker, trying to get through Macy's with 2 doors, not a button. All right. I'm probably the only one with the lime green rollers, but that's another story. All right. Resilience for how much does it take away for you to have pain, to have weakness, to live with MS, the uncertainty of what is your MR, what is your future. Y'all know. The rest of us had to learn, and I will tell you, we are impressed. But it doesn't mean that you can't continue to work on those skills, all right? And when you get to the point where you're crying and tired, call somebody, not your husband. All right. This one is another one just looking. I just really was amazed at, I was looking for a good, there are some wellness, psychology has all these nice little charts. I was looking for one that just kind of encompassed, and I just thought, gosh, even the veterinarians are having problems. Most of us bought a dog. Thank God for Harley. Harley is my dog. He saved both of us, I think, really during the pandemic. We'd bring him in the office because there is something about that connection. So finding another way. With that, I'm going to say thank you and stop. Stuart has been getting closer and closer to the stage. I think that's code word for stop.
That's code word for you done.
Oh, I'm done?
Yeah.
No,
I'm joking.
No.
All right, so anyway, I do want to thank Dr. Mary Hughes. I hope that you all can thank her as well.
Thank you.
That was an excellent dialogue. I'm going to get down. I'm going to take questions from the audience, all right? But I also wanted to know that I got questions for you.
Okay.
I got questions for you.
Yeah, no.
All
See, I
right.
try to cover all his bases, but he still has questions.
Well, I'm going to find questions of things that you didn't ask about, all right?
Okay.
Or speak about. All right, and then we're going to ask the online audience as well. If you have any questions, please type them in online. We will get to the questions. I'll be going back and forth, running around the room. And by the way, I too have a special boot. For those locally can see it. But this is to hold my foot to my leg, all right? Because the doctors wanted to fuse it and make an L and not have any mobility for that, all right? But I do find a way to get around it and do what I got to do to be able to provide for all of you, all right? And that keeps me going. And I too had COVID back in January. I forget what month it was, all right? But
2021,
the first thing I said is I'm not laying down to sleep. Second thing is, God, I still got a lot of work to do for the MS community, and I got to be out there in just a few weeks doing it again, all right? So let's get around and get some questions going, all right? Who's got a hand up?
I can tell you. Yes,
I know that young lady in the middle.
Woman I've never met before.
I know that young lady in the middle's got it.
Woman I've never met
And she came up 2 hours just to see you.
I know, and I always appreciate it.
I have a few questions, but I'll start with two. One, okay. I missed the presentation on Evishield. Can you explain what that? I was writing down some questions.
Okay, you were so busy writing questions, you weren't listening.
So I want to know what it is and what it does.
EVU Shield, all right, and it's an emergency use antibody against COVID. And it is effective against Omicron. Who knows what the next variant's going to be? And depending on what your treatment is, you certainly need to discuss that with your neurologist. And I would say you may even have to educate your neurologist and your primary cares because it's not been well advertised in South Carolina, but it is available here. And so the idea is that if we know that you are not going to be as well protected from vaccine, can we give you the antibodies to give you additional protection before you catch it? All right, so you have to be COVID negative. If you've had it, you have to wait 90 days in South Carolina for whatever reason, because it's limited use, limited availability. All right, so it's trying to be ahead of the curve.
Great, so thank you for that. And I had some questions for you about Evishield as well, which I was writing before you even got to the topic. So the National MS Society is letting people know about this, but it seems that only the true MS neurologists know about it. And what is happening then for the access to good care for everybody else in the United States that are on B-cell depleters of whichever drug it might be, all right? And how are they going to learn about this?
So one of the things that So why do I get up on a Saturday? Thank you. I was doing all the hand motion. Nobody else in the whole car was like, this means drink, please. Thank you.
Wait, is there alcohol in it?
Not yet. Although, the alcohol use in women went way up during the pandemic.
I think it went up
and
with
so we need to be
everybody.
aware of that, women. And I read that statistic, then I was like, wait, every time I go to Aldi's, when I was going, before I broke my foot, I was going, well, a bottle of wine for $5.99 ain't a bad thing. So that's just a statistic. So EvoShield, you are responsible for your own education, right? I could never get away with that. They didn't teach me that in school. My mom would say that. Yeah, we got some mom daughters in here. Could you get away with that one? They didn't teach me that in school. Doesn't mean you don't need to know it. And so these programs and other programs like them that had to go from in-person to virtual to hybrid, knowing the websites that are peer-reviewed, good quality information, the MS Views and News. Nobody corrected me. The National MS Society. All of the pharmaceutical companies have websites about their drug. The EvoShield, when I first, I read, and I'll be honest, I read it on the National MS Society website. I said, what is that? And I'd never heard of it. I kind of went to, anybody else in the office heard about EvoShield? Nobody had heard of it. And I had to call the state to find out, do we have it here in South Carolina? And my patient was the first patient that ever been given it. And so they were trying, so the information is that's why you're here, right? Now I thought you were going to ask me a lot more about it, because I will say, when it's an emergency use, there's not a lot I can tell you about it, right? But that's why you show up for things like that. That's why you watch the videos. That's why you go to the websites. That's why you say things to your surgeon like, I'm glad the x-ray looks great, but this fire in my foot, can we talk about that? Right. He never heard, he was like, sometimes people take meds for it. I was like, my neurologist kicked in. Would you recommend gabapentin or Lyric or Cymbalta? Which one would you recommend first, right? He said, what do you think? But anyway, which kind of got me. All right. So I think it's all, the National MS has a front page and center.
Yes.
Right? But you got to go to the websites. Right? You got to be there.
Actually find it on their website. It's not.
Well, it was.
It's not.
Okay.
Okay. Anyway, it was.
It was.
It was. And I asked the National MS Society what they're doing for all the patients out there that don't have their, as their MS neurologists, being those that are frontline caregivers or care providers out there. They are getting out the word. They're writing to or sending out documents to other neurologists around the country.
What I think was different, I thought was interesting, I'm sorry to interrupt you, but Tampa, I spent a lot of time on the internet yesterday. Tampa General Hospital was advertising, we now have EvoShield. If you are in one of the following categories, get in here. Right. And I think that's because Florida had a real hard time with COVID. It has a whole lot of people. It's not like South Carolina didn't have a bad time with COVID. We did, all right? But our hospitals are not front and center saying, we have EvoShield. And I think that's culture. I think that's politics. I think that's money. I don't know.
We just had a governor that said otherwise. Everybody else had to make a big deal about it.
Huh?
All right, next question.
Okay, with MS, I know that we have an overactive immune system, and a lot of us do take immunosuppressant drugs. So for those of us that are immunocompromised, should we be taking or some type of supplements to boost our immune system, or is EvoShield kind of like the answer for that?
So I'm going to break apart parts of what you just said. Most of you are on immune modulating treatments, not necessarily immunosuppressants, all right? And depending on how your immune system is being modulated, depends on what your body's ability to fight off COVID, all right? So that's to say that a little bit different. The second is your immune system is not underactive. It is acting too much. It's overacting. So for every time I hear about somebody who is taking something to boost their immune system, I kind of cringe a bit because A, I'm not sure how effective it is, but B, Do you need your immune system boosted? Right, I'm working all over hard trying to modulate it. Here you are over there boosting it. So that's where we get into the, so Stuart help me. Balding, John Bowling. Bowling.
So, yeah.
He
Dr.
has a
Bowling out
website.
Right.
Right, so there are resources there. I'm sorry, I can't get it out. Can you say it?
Bowling?
He has a website. Is it Bowling? Has a website that you can go and look up various supplements.
Right.
And they won't tell you if you should take it or not, but it'll give you the positives as known, pros, cons, and the unknown. All right? What is very important is that you tell your healthcare providers, all of them, about it. Okay? And what you're trying to do. So, for example, I heard this one just recently. Dr. Williams shared with me that I probably shouldn't have said that. Okay, somebody shared with me, it's too late now. A patient came in and said he was taking Epstein-Barr virus tablets to help his MS. First of all, I'm pretty sure you can't put no Epstein-Barr virus in a tablet. She looked it up, it is a thing. You can buy Epstein-Barr virus tablets. I suggest you save your money. And we just talked about trying to eradicate it. He was trying, right? He was in the ballpark, wasn't quite there. So I think that's why you really need to be able to, because somebody, my retirement plan is a Hughes multivitamin for MS. You got to take it multiple times a day, exactly a certain way, and it's going to be expensive. Because therefore, it must work.
It's Alan Bowling.
Alan Bowling,
And
yes.
Alan Bowling's got a comprehensive MS care center, and he's got a comprehensive MS care website.
Right, it's fabulous. All right, and NIH has similar resources for complement. It's just a little harder to comprehend.
Right. You could Google it and find it.
It will be. Oh yeah, not the supplement. Google the resources.
That's right.
Yeah,
That's
be
right.
careful with that.
Speaking about the resources that are available for, actually forgot what I was going to say. I don't remember. Let's let Doctor continue for a moment. Hey,
It's
I got
the
MS,
question
right?
phase.
Oh, I remember what I was going to
Like,
say.
I need a question to answer.
So I'm going to go around to different people for their questions. But I had COVID back in January, and it was recommended to me by by healthcare people like a Dr. Bowling, who suggested that I get onto short-term to the therapies that promote the immune system. Okay, to get rid of this as quickly as possible.
Such as
high formula vitamin C, such as some other drug names that I don't remember the name of, such as tripling up or doubling up on my vitamin D intake.
Right. Yeah.
All right, but there were a few other drugs as well, not drugs, supplements for me to take.
Yeah.
And again, I did get rid of it, but I do have long haul now. I'm a long hauler.
Yeah.
Great. Okay, next question.
Well, wait a minute. You didn't give me a chance to talk.
Oh my
So
gosh.
I too had COVID.
I thought it was my turn.
And I didn't get up really fast. I was down for the count. I was down. But yes, my primary care physician gave me a sheet with vitamin D, elderberry, baby aspirin because of the increased risk for blood clots. But that needs to be tailored. I don't want anybody to just go and write down, Dr. Hughes said take baby aspirin, because you might be taking something else that you don't need to be on that aspirin. But that was short term, right? We're not talking about long term. And COVID kills. So we don't like saying that, right? We're like, oh, we don't decide whether we're going to take the vaccine. No, COVID kills. I don't know if anybody's surprised by that, but it does kill. The long hauler syndrome is real, and it's not... we're still working on that one.
It's definitely not pleasant. A lot of it replicates actual MS symptoms,
Right.
but it then multiplies those symptoms by tenfold.
So if it's cognition, if it's fatigue, and long hauler means you have symptoms that are at least 3 months, and we notice at least 3 months, we didn't say NZ. So there's a lot of attempts there's a lot of research trying to go into how can we affect that. But every decision, like I never say take 2 vitamin C tablets, because that's different for you, that's different for you, that's different. You might already be taking 10, you don't need 2 more, right? And so we need to be able tailoring these recommendations, yes.
So I actually, once the EVU show got released, of course I'm one of these like all over stuff. Once I found my spike protein antibody amount after having 3 full shots.
Yeah.
I saw SC-DHEX thing on EvuShield, and of course it says, if you're a provider, send us the thing, we'll tell you about where to get EvuShield. So I said, well, hey, where's this located? I'm not a provider. So they sent me the email. There's 5 locations in South Carolina, and I called the Greenville location, and they said, well, hey, who's your provider? So, of course, my MS provider's in Georgia, but they said, well, hey, we send them to the internal doctors around here.
Yeah.
Or just have them call us. There's a form you have them fill out if you're on an immune suppressant. They check the boxes. They only got 40 doses. This was in January. And they pick through. I got one of them. It's not hard. Just, I advise you to go do it.
Yeah.
But I sent Stuart the list of the infusion places, so where they have the locations, but your doctor can, if you tell your doctor and talk to your doctor can request a form, get it filled out, send it over there. If they have available doses, there's one in Greenville, the Greenville Infusion Center.
It's any of the Prisma Health Health System. Prisma Health Systems are yes.
Ambulatory infusion, and then Spartanburg Regional has them as well if Prisma doesn't have any. So just FYI, I did send him the list of the 5 places in South Carolina.
Coney has some, so yeah, it's been a real it was a big challenge to get it started.
All right.
Yeah, let's say, but it is.
Before I get to you,
people
Cody, let me
tolerate it
take
well.
a question from online. All right, question. Sorry about that, but question from online is a person wants to know what kind of medications for MS are given to children that were diagnosed with MS. And they gave me different age groups of somebody like 13-ish, 10-ish, and 5-ish.
So I don't know if we're that specific by age, right? There are, and I'm going to be very vague, there are trials that have been done in children. And there are drugs that are FDA approved for children. There are only 1 or 2. But it's like anything else. We have to treat the MS like the MS needs to be treated, right? And so off-label use in pediatrics, compassionate use. So that really needs to be a discussion with that individual. I sound like a lawyer now. Yeah, I know who the lawyers in the room are. So that's a discussion, but it really needs to be a discussion with that provider, right? Because it depends on what the child has been on, what their other comorbid, if they failed this drug. So it's if prior approvals are difficult for adults, prior approvals for kids can be very, but that's what you pay your doctor to do. And so.
Okay, thank you.
Not enough, but you pay the doctor. I'm just kidding.
Thank you.
That's what you pay Nicole to do.
Okay, I saw on the news recently where there have been 3 patients that have been cured from HIV by stem cell transplants, I believe. And I know that Selma Blair recently had one for her MS, but however, she's still on a cane, I think. And I know you briefly touched on the stem cell transplant. I'm just wanting to know your thoughts on, I know it's dangerous, but if a patient was really, really doing very poorly with their MS, how well do you think it would work for treating MS?
So I'm going to separate those 2 conversations. I am not Selma Blair's physician. I certainly have followed her course because we're all interested. One of the challenges, thank you, it's like, I can't feel my fingers now. You're good at reading body language. None of y'all got that I can no longer feel my fingers. So sometimes people have a platform. Selma Blair has a platform, right? A lot of followers, a lot of watchers. That doesn't necessarily mean that her experience and her communications are translatable to the vast majority of people living with MS. All right, I'm gonna leave it there, all right? Now let's go over to HIV and Cure. So what they have been able to do is to take the virus to undetectable levels. Now, undetectable levels does not necessarily mean it's not there. Undetectable means so low we can't measure it. Does that make sense? All right. That is revolutionary, because if it is so low we can't even measure it, then what's the chances of you being able to transmit it? One of the things, for example, in the TARA studies, they're looking at the Epstein-Barr virus, is they're trying to look at can we decrease your titers or that show that you've been exposed to Epstein-Barr virus, your latent infection, right? So I'm cautious with what is a cure. The National Ms Society went through a whole a couple years ago of like, what is a cure? If you don't have any more relapses and you don't progress, is that a cure? Well, wait a minute, I'm kind of selfish. I also want my strength back, and I want my cognition. You see what I'm saying? So the definition of what is a cure. Undetectable levels, and if you can't detect the levels, the likelihood you could pass it is essentially zero. That is, in a form, a cure. All right? Selma Baer is her own conversation. All right?
Okay, I'm over here. Sorry about that, but we got some online questions to ask. All right, and the first one, back to Evusheld. Are you a candidate for Evusheld if your COVID antibodies are naturally high, but on a DMT that happens to be an immunosuppressive drug?
So there are no requirements that the tests that we are doing to see if we have COVID antibodies were not designed necessarily for that, all right? And so there is no requirement to have the antibody test to do that. Early on, I was trying to do that. I have no idea what to do with that data. That's not what it was developed for in the first place. And so it's not a requirement. Yes, if you are on a specific drug, you, by FDA guidelines, are a candidate, but that also needs to be discussed with your individual physician. All right. But boy, it'd be nice to have naturally high COVID antibodies.
Okay, first let me ask if there's anybody in the room that I missed that, okay, raise their hand. I'll be back to you on this side. Anybody online, if you have questions, please type them in.
Thank you. Dr. Hughes, you mentioned like with the axons that once they're broken, they typically can't be repaired. But how does all of that play into with the remyelinization and all of that? Like if there is a drug or whatever treatment that comes along that allows for the remyelinization, can it get to a place to where, I guess that kind of piggybacks on what she's saying, is to where your scars are healed and potentially reversing?
Yeah, so you're asking an excellent question. So what if we can remyelinate, but there's no axon there to remyelinate? Or the axons aren't connected, right? And that's been a point of conversation to say, are there ways that we can protect the axons? All right, and so that's why looking at some of these newer treatments, if we can decrease how they're being impacted, can we protect them? But this is unfortunately an ongoing process from the early stage. We thought axonal damage didn't happen until you'd had MS for years and years. We now know at the very earliest detectable, as soon as we find you, there still is. When you've read about MRI, if you've ever had your MRI read and the neurologist said, very unfortunate term, man developed it, but it is what we use, you have black hole formation. The black holes are reflection of the axonal loss, right? Most of us don't have black holes. We have light gray. We have, dove gray, we have misty gray, just what I'm saying. The blacker the black holes, though, the more axons that are lost. So we can see this on an MRI, and we know from the very beginning it is there. One of my, when you listen to a presentation and you're learning for somebody else, right? I'm learning for people living with MS, but it kind of gets you too. So nutrition talks, I try to stay away from anything that says nutrition with MS, because then they're going to tell me I should be eating less too. But the other is exercise. So one of the conversations and recommendations that I heard a number of years ago is that if we're doing studies in animals and we're trying to look at axonal, we don't let them sit there. We exercise them. And so that's one of the rationales for keeping people as active as possible, no matter what stage impact MS has on you. All right, that's the first thing. And then that's one of the reasons why perhaps we'll get even better. I mean, I guess if we could keep your axons, then and we can remyelinate a healthy axon, would you see improved function? Actually, there's a term that every time I say it, I mean, I know I'm getting old and I'm kind of a nerd here, but every time I say sustained disability improvement, that is now an outcome for a number of studies. We looked at clinically defined progression. That's been an outcome. We said if patient A is here and patient B was on the study drug and they progressed this point or less than this person, right? One person progressed less, that was an outcome. We never said if this person's here and this one's got the study drug and they see improvement, right? Have you ever heard me tell you that when you go on a drug that we are looking for improvement in your neurologic status? We're whispering that. We are, some studies are measuring that. One of the things that I think was a point for one of my virtual presentations not mine, but listening, was someone has said, we measure clinically defined progression over 3 months and 6 months. But it takes longer to climb back up a hill than it does to fall down the hill. And so when you're looking at clinically defined improvement, sustained disability improvement, we may need to be measuring that at a year, 18 months. And I've seen that phenomena when we still whisper it, is Baclofen Spasticity patients are probably our best example of that. So we can measure your spasticity, we put you on medications, we have you managed, and then you start complaining about, or you start noticing, but you usually complain, like, now I'm wobbly and you're looser than you used to be, and you don't need as much medicine to treat that symptom. Is that evidence of sustained disability improvement if you need less medicine? And on the drug I'm thinking about, we usually, if we see it, not everybody, but we've seen it enough times that we go like, let's check your tone, let's check your spasticity. Usually about 18 months. So we're getting there with saying sustained disability improvement.
Thank you. With regard going back to Epstein-Barr, the information that came out recently basically said to people that you must have had Epstein-Barr if you got multiple sclerosis. I mean, it was worded like that in many places. Yeah. And so people were writing to us and saying, I didn't have Epstein-Barr, I didn't have mono. I mean, what are they talking about? And yeah, so.
Asymptomatic infections.
Right.
So my sister had really, remember when back in the day, when one kid had chickenpox, your mom put both of you together, so just get it over with so everybody can get chickenpox, be done with it. Right, now they have vaccines. Epstein Bar Virus, my sister had a very severe case of Epstein-Barr, actually missed school, which that didn't happen in my house. You went half dead, so that's how bad it was. I mean, she really was very, very ill from her mono. I was fine. But if you test me, I've had it. I was asymptomatic, okay? And so the average age of getting, when you start testing people for whether they've been exposed to Epstein-Barr virus, under the age of about 13, it is very unlikely that you will test positive, all right? It's one of the reasons why it's been called the kissing disease, right? 13, 14, 15, 16, y'all have heard it called the kissing disease. That's when we start seeing it. And then adulthood, the number is very high. Most of us are asymptomatic infections. One of the thoughts is that if people have more severe cases of mono, right, more severe infections, does that raise their risk? And if you go the other way and say, how many of the people in the room had severe mono, you're going to hear more people with MS than you would see it with a group of people who did not have MS. All right. So it's probably a trigger, and it kind of makes sense. If you have a really bad case of a virus that tends to look more like well, who knows what it looks like, but the body don't like it, right? Then your immune system is going to rev higher than somebody who has a milder case.
I had mono, and I was very happy not to go to school. But my parents weren't, and I got stuck with a tutor for 4 months because I had it bad.
Okay. So, I mean, you don't hear those stories very often. I mean, literally, we didn't miss school. all right? And the school had to like send my mom a note, say, send this child in here with that again, to get us, just to miss school. And she was home for weeks.
My last question I have is for a friend that could not be here today. I think I already know the answer. I just want to know your thoughts on it. Not pertaining to anybody particular patient, but just across the board, an older MS patient.
That's when she's trying to get me to answer a question. I'm probably going to say, talk to your neurologist, but go ahead. I see you trying.
An older MS patient that is stable. What are your thoughts about removing this patient from DMTs? I know my answer.
Controversial. And if you put 100 neurologists in the room, you're probably going to get 3 different answers. One is going to say stop. The other one's going to say continue. And the third opinion is going to be stop, but if they start having problems, put them back on. MS drugs are expensive. So if it comes down to, are you going to eat or take your meds, and you're over the age of 80, because, old's getting, what is old? That alone is the question. What is old, all right? The other thing is people will say, she's been doing great. Well, we hope our drugs, right, are doing well. Have we cured MS? We know it goes through different phases of manifestations. And it's a heck of a time to have a relapse when you're 82, because your recovery is not good. Have I seen optic neuritis in 80-year-olds? Yes. Right? I had a competition for a while. Who's going to be, I shouldn't tell you how the competition ended, but who's going to be my oldest MS patient? They'd check in on each other. All right? Unfortunately, competition's over for both of them. But, they were in their 80s. So that's a very hard. So people have done studies with first generation MS drugs, and I think that even when you ask. So first generation's your beta serons. They said, well, if we stop your beta seron at the age of 60, all right. First of all, we would not even compare the efficacy of beta seron to what we have available now, right? So maybe, certainly better to be on than not. Certainly beta seron, as the first FDA-approved drug for MS, was revolutionary. But I don't know a whole lot of folks that are still on it. And if I hear somebody getting started on it, I'm like, what kind of doctor are you talking to? Because we have things so much better, so much stronger, so much better. So that's a very complicated conversation. If you're active and you are doing great, then I don't see a reason to stop it. I had this conversation just this week with one of my 80-year-olds, all right? And the assistance programs don't exist, and, what their copay was going to be, and, we had that conversation. I'm not going to tell you what the answer was, because that was individual to that patient. Yeah. But if it ain't broke, don't fix it. It's been my motto in many things in my life.
Thank you. I have a couple of remaining questions from online, and then we're going to call it an end of the day, all right?
Okay.
So the first one is probably a very short answer, and this person can't really do it until she reaches a certain level, but she wants to know where she can find reliable information and how to donate her brain for MS study upon her death.
So first of all, thank you. Because for people who have made those donations, we've learned so much. We've talked about it today, right?
You can't thank them.
Well, I thank her for considering it. And I thank all those unnamed folks who did, right? I thank all those donors who gave blood. So I can thank them, Stuart, if I want to, Lord. So the challenge is that you really need to be near a center that accepts the donations. All right, and so we've looked at this before. There are brain banks. Fox, I don't know, people move around centers, so I'm like, Fox, are you still at the Cleveland Clinic? I don't know where he is right now. He is employed, but he may be employed in a different location. I don't mean to say that way. But I know we went through the process of somebody wanted to donate, and the logistics for trying to get the brain from South Carolina to the Cleveland Clinic were insurmountable. So I think they'd have to contact their nearest academic medical center and see. But the other thing is that even if it's not a brain donation for specific MS study is those who are willing to donate their bodies to science. That's an incredible gift, all right? And we learn so much from that as part of the training process. And that's still a way of giving back, because we try to raise the conversation of MS in people in medical school, right? And while it may not be for a specific trial, those students seeing MS, you don't forget what you've seen.
Thank you. All right, last question. Person writes, after failing on your second attempted DMT, under what circumstances would an MS neurologist recommend going back to the first DMT that was also failed, as indicated by many new lesions on an MRI?
Ooh, you know how I normally don't answer questions? That's just plain crazy. If the first drug didn't work and your second drug didn't work, we're going to try the first drug again? I can't think of a circumstance. I mean, there must be some really unique circumstances around that. Now, the other thing is that once upon a time, well, I'm old enough to say once upon a time when there were 1 FDA-approved medicine, 2 FDA-approved medicine, 3 FDA-approved medicines, we did that because we didn't have a choice. We only had 3, right? We only had 4. We have 20 plus, depending on how you're counting them, 16 plus. There are MS trials that are available. Why on earth would you go back? So I don't know what the circumstances are. In my office, I think it'd be highly unlikely to happen. I would seek a second opinion. I believe in second opinions. Sometimes faster than others.
Thank you very much.
Because if you tell me you keep getting new lesions, I'm like, wait a minute, we've got drugs that are so effective now. That is really, really unusual to hear. That's the good news. Y'all are tired, I'm tired. Stuart, I'm done.
I'm done too. Thank you. Everybody, thank you, and let's thank Dr. Williams.
Dr.
Hughes.
Williams.
Not Dr. Williams, Dr. Hughes, sorry. They practiced together once upon a time, though.
She was my fellow.
That's right. You practiced once together, and we're going to be going to Augusta hopefully later this year. But I do want to thank you. Fist pump, right? Traditional fist pump right now. I want to thank everybody for being online today. I want to thank everybody that was in attendance. So if you like watching our programs online, please get registered for these and tell your friends about it. Dr. Hughes, again, thank you very much for being here today. And first off, I want to say goodbye to everybody online. Thank you very much for being here.